Right, diving right in. Today's deep dive is all about renal function. And since I know you're a medical professional, we're going to skip the basics
Yeah.
and really dissect Chapter 2.
Yeah.
No need to treat you like you're just starting med school. We'll be focusing on the nephron, GFR regulation,
Okay.
renin-angiotensin system, all that good stuff.
Sounds good.
All with a clinical lens, of course. So
Yeah. Let's
where should we start?
let's start with the juxtaglomerular apparatus, that
Okay.
tiny but mighty structure.
Right, the chapter highlights it as key to regulating renal function. But it always kind of struck me as more of a behind-the-scenes player, you know?
Really?
What's something about the juxtaglomerular apparatus that might actually surprise even a seasoned nephrologist?
Well, I think most of us, we know about its role in renin release.
Right.
But what I think is really fascinating is its sensitivity to even the slightest changes in sodium chloride delivery to the distal tubule.
Oh.
It's like this finely tuned sensor
Right.
constantly adjusting to maintain that critical balance.
So even subtle shifts in sodium levels can have a ripple effect on the entire system.
Exactly.
Yeah.
And that sensitivity ties directly into the concept of glomerular filtration.
Right.
Chapter 2 really emphasizes the complexity of GFR regulation,
Yeah.
going beyond just the basic Starling's forces.
Yeah, it mentions both autoregulation and tubular-glomerular feedback as critical players.
And it's the interplay of these mechanisms that I find the most intriguing.
Okay.
So think of autoregulation as the kidney's first line of defense
Okay.
against blood pressure fluctuations.
Mm-hmm.
It acts like a buffer, ensuring a relatively constant GFR despite changes in perfusion pressure.
Interesting.
Yeah.
So then tubular-glomerular feedback steps in as a fine-tuner,
Right.
making adjustments based on sodium chloride concentration and flow rate in the distal tubule.
Exactly, the macula densa. That specialized group of cells in the distal tubule acts as a sensor, communicating with the afferent arteriole to adjust glomerular pressure as needed.
It's almost like a mini nervous system within the kidney,
Yeah.
responding to local cues and making real-time adjustments.
It is quite remarkable.
Yeah.
But even these intricate mechanisms
Right.
aren't always enough.
Okay.
That's where the renin-angiotensin system comes into play.
The RAS.
Yeah.
The chapter provides a pretty detailed overview of this hormonal cascade. But what I thought was really interesting was the emphasis on angiotensin II's multifaceted role.
Absolutely. Yeah, it's not just a potent vasoconstrictor.
Right.
Angiotensin II also has a direct effect on glomerular filtration,
Okay.
specifically by constricting the efferent arteriole.
Which increases glomerular pressure and helps to maintain GFR
Right.
even when blood pressure drops.
Precisely. It's a brilliant compensatory mechanism, but it also raises an important question. What happens when these compensatory mechanisms are overwhelmed?
Right.
Or when they become maladaptive?
That's a crucial question, especially when we consider the clinical implications.
Yes.
It's a reminder that understanding these intricate pathways isn't just an academic exercise,
Right.
It's essential for making informed decisions about patient care.
Absolutely. And that's what we'll explore further as we kind of delve into the clinical aspects of
Right.
GFR measurement and the interpretation of lab values.
Right, because even a seemingly normal creatinine level can mask underlying pathology, especially when those compensatory mechanisms are working overtime.
Exactly.
But let's not get ahead of ourselves.
Agreed. Yeah, we need to fully appreciate the complexity of the system
Okay.
before we can translate that knowledge into clinical practice.
So we've covered the juxtaglomerular apparatus, GFR regulation,
Yep.
and the RAS.
Right.
What else does Chapter 2 highlight about the physiology of renal function?
Well, it also delves into the role of prostaglandins. Those locally produce vasodilators that act as a counterbalance to the vasoconstrictive effects of angiotensin II and norepinephrine.
Right, it's like a tug of war with these opposing forces,
Exactly.
constantly vying for control.
Yeah, and the chapter mentions that the balance can shift depending on various factors, including renal perfusion pressure.
So under normal conditions, a drop in renal perfusion pressure triggers the release of both angiotensin II and prostaglandins.
Right, and the net effect on GFR depends on the relative strengths of these opposing forces.
So it's not just about the presence or absence of these factors, but rather their dynamic interplay.
Precisely. And that interplay can have significant clinical implications,
Okay.
especially in patients with compromised renal function. For
Right.
instance, in a patient with pre-existing renal disease, the use of NSAIDs,
Yeah.
which inhibit prostaglandin synthesis,
Mm.
could tip the balance towards vasoconstriction and further compromise GFR.
That's a great point. It highlights how understanding these seemingly esoteric physiological mechanisms
Right.
can actually inform our clinical decision-making.
Absolutely.
It's not just about memorizing pathways.
Right.
It's about understanding how they function in the context of a living, breathing patient.
Exactly.
So we've talked about that big picture of GFR regulation,
Yeah.
and all the players involved.
Right.
But now let's zoom in on those microscopic workhorses of the kidney,
Yeah.
the nephrons.
Yes, the nephrons. Millions of them each. A tiny filtration factory.
Right.
Orchestrating this intricate dance of reabsorption and secretion.
The chapter really emphasizes that it's not just about filtering waste. It's about reclaiming those valuable substances,
Right.
fine-tuning electrolyte balance,
Yeah.
and ultimately producing urine that's perfectly tailored to the body's needs.
Exactly. And that precision is achieved through this complex journey that the filtrate takes
Right.
through the different segments of the nephron.
Okay.
So we start with the proximal tubule, which is responsible for the bulk of reabsorption.
Right. Chapter 2 mentions that about 2/3 of the filtered sodium chloride and water are reabsorbed in the proximal tubule.
Yeah.
But it's not just passive diffusion, is it?
No, not at all. It's a highly regulated process.
Okay.
Involving active transport facilitated diffusion.
Right.
And a whole host of transporters working in concert.
The chapter highlights the sodium-potassium ATPase pumps as, key players in this process.
Absolutely. Those pumps are constantly working.
Right.
Pumping sodium out of the proximal tubular cells and into the interstitial fluid, creating a concentration gradient that drives sodium reabsorption from the tubular lumen.
So as sodium goes,
Yeah.
so goes water, following that osmotic gradient.
Exactly.
So sodium reabsorption is like the driving force
Yeah.
for water reabsorption in the proximal tubule.
Yes, but it's not just sodium and water that are being reabsorbed.
Right.
The proximal tubule is also where we reclaim glucose amino acids, potassium phosphate, bicarbonate.
Wow.
A whole smorgasbord of essential nutrients.
Like a highly efficient recycling center, making sure we don't lose those valuable substances in the urine.
Precisely. And it's not just about reabsorption.
Right.
The proximal tubule is also involved in secretion,
Okay.
particularly of organic anions and lephations, including many drugs and toxins.
There's a two-way street,
Right.
both reclaiming and eliminating, all happening simultaneously in this one segment of the nephron.
It's a testament to the efficiency and complexity of the system.
It really is.
Now, as the filtrate leaves the proximal tubule, it enters the loop of Henle,
Right.
where things get even more interesting.
The loop of Henle. That's where the kidney establishes that concentration gradient in the medulla, right?
Right.
The chapter mentions countercurrent multiplication as the key mechanism. I always found that concept a bit tricky to grasp.
It is a bit mind-bending, but think of it as a system that uses active transport and differences in permeability to create a gradually increasing osmolarity as you go deeper into the medulla.
So the descending limb is permeable to water, allowing water to be drawn out by that increasing osmolarity of the medullary interstitium.
Exactly.
And the ascending limb actively transports sodium chloride out,
Right.
further increasing that osmolarity.
Exactly. It's a brilliant system that allows the kidney to concentrate urine when needed,
Yeah.
conserving water and maintaining fluid balance.
It's amazing how these seemingly simple processes, just repeated over and over, can achieve such sophisticated results.
It really is. Now, after its journey through the loop of Henle, the filtrate enters the distal convoluted tubule.
Okay.
Here we see the fine-tuning of electrolyte balance with sodium and chloride reabsorption under the influence of aldosterone.
Aldosterone again.
Right.
That hormone seems to pop up everywhere in renal physiology.
It's a key player, especially in regulating sodium balance.
Right.
And the distal tubule also secretes potassium and hydrogen ions, further contributing to electrolyte homeostasis.
So it's another site of both reabsorption and secretion, just like the proximal tubule,
Yep.
but with a different cast of characters.
And finally, we reach the collecting duct, the last stop on this incredible journey.
Right.
Here we see the final adjustments to urine concentration and volume, largely under the control of antidiuretic hormone, or ADH.
Right. ADH increases the permeability of the collecting duct to water, allowing for that fine-grained control over urine concentration.
Exactly when ADH levels are high, more water is reabsorbed, resulting in concentrated urine.
Right.
When ADH levels are low, less water is reabsorbed, producing dilute urine.
Okay.
And with that, the filtrate now transformed into urine is delivered to the renal pelvis and onward to the bladder.
It's amazing to think that this entire process, from filtration at the glomerulus to excretion from the bladder, happens millions of times per minute in each of our kidneys.
It's a symphony of cellular processes all working together to maintain that delicate balance that we call homeostasis.
Yeah.
But as fascinating as this microscopic world is, we can't lose sight of the bigger picture.
Right. We need to translate this knowledge into clinical practice, into understanding how these processes can go awry and what we can do to intervene.
And that brings us to the clinical significance of GFR and how we measure it in a way that's meaningful for patient care.
So we've covered all this intricate machinery of renal function, but how do we actually assess that function in a clinical setting? I mean, we can't exactly peer into the nephrons with a stethoscope.
Haha, of course not, although would that be fascinating? But you're right, we need these reliable tools to measure GFR.
Right.
And Chapter 2 dives into that.
Yeah, the gold standard, as the chapter mentions, is inulin clearance, but
Yeah.
in everyday practice, it's just not feasible.
Exactly. It's cumbersome and time-consuming, not something we can routinely do in a busy clinical setting.
Right.
That's why we rely on creatinine clearance as our workhorse.
Creatinine, a waste product of muscle metabolism, freely filtered at the glomerulus.
Right.
Makes sense. But the chapter does point out that it's not a perfect measure.
Right. Creatinine is slightly secreted by the tubules.
Okay.
So creatinine clearance will overestimate GFR to a small extent.
But it's still a decent approximation, though, especially in patients with relatively normal renal function, wouldn't you say?
Yes, particularly when we consider the clinical context.
Right.
And thankfully, calculating creatinine clearance is fairly straightforward.
Urine creatinine concentration multiplied by urine flow rate
Right.
divided by plasma creatinine concentration.
Simple in theory, but there are nuances.
Okay.
The chapter emphasizes the importance of considering factors that can alter creatinine levels independently of GFR.
Right, like age, muscle mass, diet.
Exactly.
All those can throw off our calculations.
For example, that elderly patient with low muscle mass might have a seemingly normal plasma creatinine, but a significantly reduced GFR.
Oh, wow.
That's why relying solely on plasma creatinine can be so misleading.
We need to look beyond the numbers to consider the whole patient.
Absolutely. And that's where the BU creatinine ratio comes in, offering another piece of the puzzle.
BUN, another waste product. But unlike creatinine, it's partially reabsorbed by the tubules. So its levels are influenced by both GFR and tubular function.
Precisely. And that's the beauty of the ratio.
Yeah.
An elevated BUN creatinine ratio, typically greater than 20:1,
Okay.
can point towards prerenal causes like volume depletion.
Because in volume depletion, you have increased reabsorption of urea, along with sodium and water in the proximal tubule, leading to that disproportionate rise in BUN.
Exactly. So the BUN creatinine ratio can help us differentiate between various types of renal dysfunction.
It's like having an extra set of eyes,
Yeah.
allowing us to see beyond the surface.
Couldn't have said it better myself, but as the chapter reminds us,
Right.
even with all these tools, there's still so much we don't know.
That ending question really got me thinking, how do we detect progressive kidney disease in a patient with seemingly normal creatinine levels? I mean, those compensatory mechanisms can mask so much.
It's a crucial question, perhaps looking at subtle changes in urinary protein excretion,
Right.
or exploring novel biomarkers, or even utilizing advanced imaging techniques. I mean, the field is constantly evolving.
It's a reminder that we as medical professionals need to stay curious, keep learning, and always question what we think we know.
Well said. The kidneys, for all their complexity, still hold many mysteries. But by understanding the fundamentals, by diving deep into the physiology, we can unravel those mysteries and ultimately provide better care for our patients.
This deep dive has been incredibly insightful. It's really reinforced the importance of not just knowing the facts, but really understanding the why behind them.
Yeah.
And to our listener out there, we encourage you to keep exploring, keep questioning, keep that thirst for knowledge alive.
Absolutely.
Your patients will thank you for it.